Hey everyone, welcome! So, if you're getting ready for the NCLEX or just trying to sharpen your skills on the floor, there's one topic you absolutely have to master: intake and output. But listen, this is way more than just counting cups and milliliters. It's a masterclass in patient assessment. So let's dive in and see why this is such a game changer. Okay, so here's our game plan. We're going to kick things off with the why, the whole principle of fluid balance. Then we'll get into the nitty-gritty of what actually counts as intake and output. After that, we'll tackle the must-know math, what your responsibilities are as a nurse, and then wrap it all up with a real-world scenario to put your clinical judgment to the test. Let's do this.
All right, first up, the principle of balance. Before we even think about measuring anything, we have to understand the why. INO isn't just some task you check off a list. Nope. It's a really powerful tool that tells a critical story about your patient's health. So at its heart, when we're monitoring INO, we're really just assessing their fluid balance. And you can think of it as a window, a direct look into some of the body's most important systems. Are they hydrated? Are the kidneys doing their job? Is their heart pumping like it should be? The clues often start right here. Okay, if you walk away with just one thing today, let it be this. This is like the golden rule of fluid balance. In a healthy person, the body is this amazingly balanced machine. Our job as nurses is to be the detectives who spot when that balance is off kilter, because that's our first big clue that something's not right. Okay, enough theory, right? Let's get practical. It's time to start counting. We're going to start with the inside of the equation, mastering the rules of intake. And this is where a ton of people trip up. But don't worry, we're going to clear all of that up right now. And here it is, the number one absolute most important rule for figuring out intake. It's so simple, but you gotta stick to it. Just ask yourself this simple question. If I left this on the counter, would it turn into a puddle? If the answer is yes, then you count it. This one little trick will save you from so many of those tricky NCLEX questions.
This is where we clear up all that confusion. On the left, you see things like Jell-O, ice cream, popsicles. They might look solid at first, but they melt, so they absolutely count. Now look at the right side, mashed potatoes, tater tots. Those stay solid, right? So they don't count. Getting this distinction right is just crucial for the exam.
Okay, so we've got intake down. Now let's flip to the other side of the scale and see how this all balances out, measuring what comes out. Being accurate here is just as important, and it means we have to be really diligent, tracking down every single source of fluid loss.
So output, it's not just about urine, right? We have to count everything we can measure. So that includes any vomit, liquid stool, and any drainage coming out of tubes or wounds. Every single one of these tells a piece of the story. So if it's a measurable fluid leaving the body, it has to get documented.
All right, we've got our intake numbers, we've got our output numbers. Now what? Now we turn all that data into something meaningful. This is the math part, and I know math can be a little intimidating, but trust me, this is super straightforward. It's all about following the steps.
Okay, people, this slide right here, it's totally non-negotiable. You have got to know these conversions, not just for the NCLEX, but for safe practice every single day. The standard unit we use for everything INO is the milliliter or ml. Patient safety literally depends on it, so you have got to burn this chart into your brain. 1 ounce is 30 milliliters. 1 cup, 240. Always, always convert.
The actual math part, it's so simple. You just add up all the intake, then you add up all the output, and the key, the absolute key, is converting everything to milliliters before you start adding. Then you just compare the two numbers. That little comparison tells you if your patient is positive, negative, or right on track. All right, now listen up. Let's talk about maybe the single most important number you need to know for an adult patient's output: 30 milliliters per hour. That is the bare minimum for acceptable urine output. It tells us the kidneys are getting enough blood flow. If you see less than that, that's a huge warning sign. So let's just pause here for a sec. I want you to really think like a nurse. You've been tracking your patient's Foley catheter for the last 4 hours, and you've only gotten 80 milliliters total. That's just 20 milliliters an hour. What should be going off in your head right now? What does that signify?
That is a massive red flag. Urine output dropping below 30 milliliters an hour is a sign of possible renal hypoperfusion, meaning the kidneys are not getting enough blood. This is not a let's wait and see what happens kind of situation. This needs to be reported immediately. The action you take right here could literally save your patient from acute kidney injury.
So this really breaks down the two main things you'll see:
If intake is a lot more than output, we call that a positive balance. The patient is holding on to fluid, which puts them at risk for fluid overload. We see this a lot with heart failure or renal failure. On the flip side, if output is way more than intake, that's a negative balance, and they're at risk for dehydration. Super common if they're vomiting, have diarrhea, or are on diuretics. Okay, let's pull all of this together and talk about what you do. Because the NCLEX, it's not just going to ask you to add some numbers. It's going to test your clinical judgment. What do you do with this information? What are your actual responsibilities as the nurse? So, your key responsibilities break down like this. First, you have to measure accurately. Use the right tools, document in mLs. Second, you educate. Teach your patient and their family why this is so important so they can help you track everything. Third, you assess. You don't just stare at the numbers, you look at the patient. Listen to their lungs for crackles, check for swelling, assess their skin. And finally, and this is a big one, remember that daily weight is actually the most accurate indicator of fluid status. Why? Because it catches all those invisible losses like sweat that we can't measure. All right, this is your cram session slide. If you're studying for the exam, you might want to screenshot this one. These are the absolute must-know facts. If it's liquid at room temp, it's intake. Urine less than 30 mils an hour is a red flaggy report. Daily weight is king for accuracy. Always convert to mils and never, ever, ever count solid foods. Got it? You know, the NCLEX loves to set little traps to check if you're paying attention, so watch out for these. They might mention a juicy peach in the question. That's a solid, don't count it. They'll list IV antibiotics. You better believe you count those. They might sneak in that the patient vomited. That's output. And the biggest trap of all, giving you some numbers in ounces and others in mLs, just hoping you forget to convert. Don't you fall for it. Okay, so we've covered the why, the how, and the what to watch out for. Now it's your turn. Let's put everything we've talked about into practice with a quick case scenario. This is where you get to put on your nurse hat and think critically. All right, here's the situation. You have a 72-year-old male patient with a history of heart failure. During your 8-hour shift, his intake was 8 ounces of water, 6 ounces of coffee, and his IV fluids were running at 125 milliliters per hour. His total output for the shift was just 250 milliliters of urine. And when you did your assessment, you heard some new crackles in the bases of his lungs. So I want you to put all those pieces together: his history, the I&O calculation, and your assessment findings. What is your priority? What would you, as the nurse, do next? Think it through. This is exactly what clinical judgment is all about. Thanks for diving into this with me. We'll see you next time.